Into the cloud. So the recording's active. So welcome, Dr. Tenenbaum. Thank you for joining us from Wellington, Dufferin, Guelph Public Health. It's a great opportunity for some of our church leaders and members to get a sense straight from public health, some guidance and direction for what we want to do around reopening. Some churches in Guelph have already reopened, and some faith communities in Guelph have already done so. Each of us in our own way, because many of us are represented by national bodies and also more local bodies, have been given direction in a variety of different ways, but we really wanted to focus in on what Wellington, Dufferin, and Guelph are looking at. We do have a few people from Wellington County on today, and this will be sent out, this video hopefully, and any sort of insights from it, we can send it out to our regional bodies so that people in the wider area do get a chance to see it and can pass it on to their leadership. So I'll turn it over to you, Dr. Tenenbaum, to offer whatever you'd like to give us, a landscape and things like that. And I thank you so much for your time and also for public health, all the work that you guys have been doing for months now. Thank you so much for everything you do. And I know in our faith communities, in mine, and I'm sure in many others, we're offering prayers and our thoughts for all your staff and yourself for all the hard work you guys are doing. So thanks.
Well, thank you very much, Reverend Borthwick. And certainly from my perspective, you know, we have our role, you have your role, we all have our parts to play. And responding to COVID-19, in my view, really is a whole of community response. And so we are appreciative of everything that you're doing to support your congregations and people who you're connected with. And it falls on all of our shoulders, and it's great to be able to work together on not just the immediate measures we took in the winter, but slowly reopening so that we're able to resume some of our normal activities. I do want to start by saying that even though we are locally not seeing the kind of COVID-19 activity that we were seeing previously, we are not quite out of the woods yet. The reopening across the province has been gradual because they do want to make sure they're monitoring activity as we gradually reopen new spaces to see if we are going to see increases in case counts, increases in hospitalizations, or increases in deaths. So over the summer, things are going to be a bit tentative and slow as we resume activities. And as well, there is a possibility that later into the year, as we get to the fall, we may begin to see more activity again. There is a lot of talk about the possibility of a second or subsequent waves of disease. It would not be surprising if, as the fall hits, I would begin to see some of those trends happening. So all that is to say that we're going to be talking today about how to begin resuming some services in different kinds of ways in the current context, but the context is changing day by day and week by week. And so there is a possibility that things will get better and we'll be able to move forward in new kinds of ways. There's also the possibility that we may see some increased challenges ahead. We may have to reduce what we do as a community as a consequence. And so, of course, last Monday, the province talked about reopening in stages, and our area was one that was entering phase 2, and that happened this past Friday. Along with that, they talked about changes for places of worship and places of faith. So now they are saying that within an indoor environment for a worship gathering, you can have up to 30% of the building's capacity coming into that space, but it is also required that you have really robust physical distancing measures in place. And so the reason physical distancing is important is because COVID-19 is spread by droplets. So someone who's ill, you have the virus in the back of your throat and parts of your airway. And so as you're speaking, as you're coughing, sneezing, those droplets of infected virus come out of your nose and mouth. So being within about 2 meters of someone, if you're talking with them, there is a risk of spreading that. And so we're trying to recommend everyone stay at least 2 meters apart wherever possible to reduce that risk. And we also know that it's possible for droplets that have the virus to end up in people's hands, end up on surfaces. And so it is possible in principle as well for that infection to spread on contaminated surfaces. And so we're looking at both those droplets being spread and the person-to-person and person-to-surface contact as being possible vehicles for transmission. And so as a consequence, there are a few really important measures that we think about, not just in places of worship, but in any setting, whether it's long-term care homes, hospitals, businesses, places where people gather to go about their days and to meet. There are some really important key tenets that need to be kept in mind that help reduce the risk. And that first one is physical distancing. So as people are gathering for in-person services or other functions of the place of worship, we are really emphasizing that it's not just important to tell people to stay 2 meters apart at all times, but to really engineer the place of worship as best you can to try and maintain that distance. That might mean, for example, if you have pews or seating, blocking off portions of those pews or seats so that people know to be spaced and that they're given reminders about where they can and can't sit. As people enter or exit the building, it might be helpful to think about how people flow and perhaps have signage or have markings on the floor that direct people that this pathway is for coming into this room, this pathway is coming out. Of course, each of you will know best based upon how your space looks, what makes sense. But if we are able to keep people from moving past one another as much as possible in close quarters, it'll reduce that close contact. As well, we are trying to reduce that direct person-to-person contact. So any activities that require person-to-person contact are really discouraged and it could be avoided if at all possible. Any gatherings that are postponable or avoidable or non-essential, we're also recommending not be done at this time. So things like if you have lunches after services or events like bake sales or the charity events, things like that, it may be worth thinking about how to do those things in a virtual environment or whether they can be postponed in some other way so that we are, as much as possible, reducing that person-to-person contact and those chances for people to come into close proximity with one another. As we're thinking about that, we're not just thinking about people attending the place of worship, but also about people who are your staff, are your volunteers, or other kinds of visitors, because all those people are people who could be mixing together. As well, when we think about the services themselves, I mentioned how it's important to avoid sort of non-essential pieces of service, but of course there are some kinds of gatherings that will be essential to people in your congregations. And for those, that physical distancing is key. As well, because of that person-to-person and person-to-surface contact we're worried about, it is important to avoid sort of passing around or sharing things wherever possible. Things that are difficult to clean. So as you're thinking about communion or passing around like a collection plate, it is really important to, as much as possible, avoid passing things person to person, or if you have to, really make sure there are rigorous cleaning processes involved so that people aren't touching things and then passing their infected droplets onto other people who are then receiving that. As well, if you think about things like books you may have in your pews, those either have to be cleaned regularly between uses, or if you're able to use disposable printout copies of prayers or hymns or other parts of the service, those are worth considering. As well, because this is an infection that can be spread by droplets, we know it can be spread when people speak to one another, but certainly if people are singing as part of a choir or as a soloist, or they are using woodwind instruments or instruments that require breathing through them, those are things that can spread the virus, and we would recommend avoiding as much as possible. There are unfortunately examples of outbreaks of COVID-19 associated with choirs where one person was singing and they had the virus and that spread to many others in that close proximity. So certainly if you were to have any need for chanting among the congregation, we recommend that it be done in as soft a voice as possible or avoided where possible. We are recommending that people who are in your space wear masks as much as possible. To be clear, these are not medical masks, but any sort of cloth face covering will do. And that's consistent with what we're recommending for other kinds of non-healthcare settings. The idea being that it keeps droplets from leaving your mouth and getting very far. As well, if you need to have a choir, really physical spacing of people out apart as much as possible is important. And you have to think about where a soloist or members of a choir are standing in relation to others, and if they're able to be behind a plexiglass barrier or facing in a direction away from congregants. That will help any droplets from entering the space where people are sitting. Certainly if you have people singing or doing instrumentation from a balcony, that could be a hazard as well if those droplets fall down. So again, all these things, the key message is avoid if you can. If you can't avoid them, then really think about kinds of barriers we can put in place to keep those droplets from being passed on from person to person, especially during some of those high-risk activities like singing. Thinking as well about other things that are going to be happening in your space and reducing the risk for infection. Cleaning is a really important piece of the puzzle. We're recommending for any business, any commercial establishment, that they have um, alcohol-based hand rub at entrances and exits. People have an easy way to wash their hands as they come in or out of any space. And we are suggesting that might be worth considering for your places of worship as well. Opportunities to wash your hands and having alcohol-based hand rub in other common spaces people might pass will also be helpful. Again, the more chances people have to wash their hands, the more often we think they'll do so, and the less chance there is of that transmission because of infected droplets on their hands. Places like, places where people meet or places where they go to use the washroom, cleaning is really important. It's important that you have a regular cleaning schedule and staff trained in appropriate cleaning. It's really important that high-touch surfaces in particular be washed on a regular basis. High-touch surfaces are places that people touch often, so think about things like light switches. If you're using books, the surfaces of the books would be important. Any sort of places that are commonly touched items like doorknobs will be important to clean at least twice a day. And we're recommending that when you clean, if you're going to use an appropriate disinfectant, that be one approved by Health Canada with an 8-digit drug identification number. Those are the ones we're recommending that we know to be effective against COVID-19. And so again, it's not just the product you use, but it's also the staff or volunteers you have who are doing the work who are properly trained on both the cleaning piece and the disinfection piece to make sure that it's being done on an ongoing basis in an effective way. So all these things are coming together to form parts of a plan. I didn't mention earlier the importance of making sure that as people are coming into your space, people are aware they shouldn't be coming in if they have symptoms or signs of COVID-19. In a lot of our spaces, whether it's healthcare, whether it's childcare, we are talking about having someone who's able to essentially act in a screening capacity at the entrance, asking that person if they're feeling well today, if they have any symptoms of COVID-19, like breathing, cough, fevers, chills, or if they have been in contact with someone who's known to be a case of COVID-19. And essentially what we're asking is that if people through that screening process identify that they're either ill or at risk of COVID-19, that they kindly be asked not to enter the space so as to protect those people who are in the space. Again, physical distancing, cleaning are all important and will all reduce the risk of person-to-person spread of droplets. If we know that someone is at higher risk of having the illness and potentially spreading to others, we are recommending that they not enter because that risk exists. So that's where you might also think about opportunities for virtual portions of congregations and ways for people like that to participate in a remote capacity to reduce the risk of having them there in person. Finally, it would be worthwhile for your place of worship to keep a log or keep a record of who you have attending your services. You might do that through having your screener keep a logbook. You might have that through people who are attending your services RSVP electronically. But having a way of keeping track of people who are coming in and out of your space will be helpful in the context of if you have someone who turns out to be a case of COVID-19. Because then it helps us in public health know who else might be at risk. It helps us contact those people and recommend to them that they either get tested or isolate or monitor themselves for signs or symptoms. So having those records will be quite important if people are going to be coming and going. And hopefully with smaller congregations and that limit of 30% of capacity at any one time, that will be a smaller number than usual, and so an easier number of people to follow up with in that unfortunate event that we have a case who's linked to a gathering. So all of those things are kind of different domains, different buckets of consideration. I will make sure that I circulate through you, Reverend Borthwick, some additional resources that I think are helpful and perhaps provide a bit more detail on some of these items. There is some really specific advice we can recommend above and beyond what I'm saying right now. But all these things are worth considering both in the context of preparing your space, in the context of having people in as part of your reopening, and as well, you have to think about how you prepare and train your staff and volunteers to make sure that you're ready, and how you communicate with your congregation and your community members. So I kind of talked through a few different domains and considerations, and I'm happy to delve into more of them with any questions that you have. Before I jump onto the list of questions that were circulated, are there any quick questions that I can, I guess, take at this time that might be helpful to address?
Anybody have any specific ones? I was given a few in advance, and I've given those to Dr. Tenenbaum, and we can go through those together if you'd like. Why don't we try to do a few and see if anything else comes up for the group that's gathered live here today, Doctor?
Sure, that sounds great.
Okay. So one of the curiosities that somebody mentioned was they had seen something that said 30% of space capacity or 50 people, whichever is less, because some of our buildings are fairly large. Does Wellington, Dufferin, Guelph Public Health have any comment on that, or just if you've got a 30% capacity of your building and you're doing the social distance, the physical distancing, then you can, if you can fit more than 50, then by all means, would that be your direction?
So I think sort of our overall direction is along the lines of fewer people gathering is better
Mm-hmm.
because it reduces that likelihood of people being in close contact, and it reduces the number of people who might be at risk if one person ends up being exposed. I know for a long time we had a limit of really 5 people as far as any gathering. That recently changed to 10, and we're now expanding in terms of social bubbles. The numbers themselves are less meaningful than the overall principle that less is better. That being said, what the provincial guidance says is that for any indoor services, the limit is 3%. That's the upper maximum of what the province is allowing. Certainly anything lower than that is suitable. For outdoor services or ceremonies, weddings, funerals, etc., it is 50 people because there is no percentage capacity that you have to keep in mind. Those are the provincial requirements. Certainly, those would be appropriate to keep in mind, but if you're able to have even smaller gatherings and that works for your setting and your congregation, that is even better.
Yeah, and anecdotally, I heard one congregation, from the way they understood their building capacity, say, for example, it was 300 people. So when they heard the 30%, they were like, oh, well, we could then fit pretty much everybody who comes anyways, because we get about, 100 or so. However, when someone did the actual measuring of like, okay, we're going to put some chairs here, measure 6 feet, measure, they could only fit in 50.
Yeah.
So they were like, oh, okay, actually it's working out. So I hear your message. Less is better. If there's ways of reducing that, that would be a good idea. Someone also said that they read somewhere, and I don't know if it was in the provincial guidelines here, people have been reading so much information from so many different sources, but it said they saw in some kind of small print that anyone over the age of 65 is strongly advised to stay home. For most of our mainline churches in the province, the typical attendants are people who are over the age of 65. So, I mean, that might certainly reduce our numbers if we say you're over 65 and you can't come. But is that a direction from public health or no?
So this goes back a couple of months, back when we were talking about, when we were talking a lot about the isolation of people returning as travelers and people for whom we're saying you couldn't leave the home at all. At that time, the chief medical officer for the province recommended that anyone over age 65 really self-isolate at home and not leave except for the most essential things. That recommendation is still in place, but it is a recommendation as opposed to a directive. And the idea behind that is that people over age 65 are more likely to have medical conditions or otherwise be at risk for the more severe complications of COVID-19. And so while on the one hand, we are thinking about reducing person-to-person contact and limiting spread more generally, we're also particularly worried about the impact infection would have upon our most vulnerable members of our community. And so those people are still technically under that recommendation to stay at home. That being said, we know that staying at home isn't realistic for every person, and people over age 65 will, in some cases, still be out and about in the community. We aren't asking people to not go to a place of worship if they are over age 65, or we're not asking you to turn those people away. But it is important for people in that age group to be aware of that risk that they face and really think carefully about when they leave the home. If your place of worship has an option for people to participate remotely or virtually, then that might be a safer option for people in that older age group, because then they don't have to leave the home to participate in those activities and to connect with members of their community. That could be a real important reason to have a virtual option if that's possible for you.
Yeah, thanks for that, Doctor. I think one of the challenges that many in our faith communities have is some of the older adults are ones that don't necessarily have an ability or a proficiency with the technology. And so we're probably aware in many of our communities that once there is an opportunity to come back to church, that older demographic will really, really want to be coming back. And so, but as you say, if the physical distancing is in place, if there's many protocols been put in place, at least and if it's less people, then hopefully we can reduce the risk for them as they do wish to return.
Mm-hmm.
One thing mentioned a number of things about staff, and people had asked about a question related to, should all church staff be tested before returning to work? Because in some cases, like I know myself, I haven't been back to the church. I've been back to the church once in 3 months. So when we start to bring our staff back and some of our clergy and music people and folks like that, should they all be tested? Would that be a good suggestion, recommendation, or is that necessary, even if they're not symptomatic or anything like that?
So right now, currently, we're not recommending testing for people who participate in the church or place of worship setting, unless they have another reason for needing testing. So they might need testing if they have symptoms, or because they are in close contact with someone who was a case or they're part of an outbreak and they have some sort of connection to a known case. In those scenarios, they should get tested as per our general recommendations. There are some limited groups of people for whom there are recommendations to be tested on a regular basis. Right now, it's focusing mostly on long-term care and retirement home staff. I will say at this point that that list of groups for whom it's recommended is evolving, and I participate in some of the working groups with our partner agencies to figure out what that list should be. And we are trying to look at what the data tells us about who's most at risk and where testing would have the most impact. And so right now, we're not recommending that in this context, but it is not implausible that that could change down the road.
Yeah, that's fair. Maybe further on that, because of the nature specifically of either clergy themselves or maybe people who within the congregation have the role of visiting people, whether that's in the hospital or in long-term care or retirement homes or in people's homes, would it be advisable for those persons to get tested, just from what you know now at this point? Like I mean, I haven't gone back to this kind of actual routine, but in my day when I was working in a normal manner, it would be possible that I'd be visiting in somebody's home all within one day, going to the hospital, visiting maybe one or more persons in the hospital, then going to a long-term care facility, possibly even going to a retirement facility. So that's all in one day. So I mean, I'd be one of those people that in the early days of the pandemic, we were talking about, some health workers who were going to various places. So just curious about that related to how public health's looking at that particular role.
That's a really good question, and I appreciate kind of getting that inside look into what that looks like. Right now, in context of long-term care, they're recommending that people who are visitors, whether they are visiting in a professional capacity versus visiting just as family members and friends, those people get tested within 14 days of when they visit. And so if they're visiting on an ongoing basis, essentially that means getting tested every 14 days or so. So that's a recommendation that technically applies in the long-term care sector, but it would be relevant to members of clergy or others who are visiting on behalf of the church or place of worship, because they have to abide by those same recommendations. So that is the one testing recommendation that applies there. I do know that we've talked a lot about the context of staff who work in long-term care, and there was a lot of concern initially about staff who are working in multiple facilities and whether or not there's a chance for those staff to, bring the infection with them between facilities and lead to spread of COVID-19. And there was subsequently a directive from the province saying that staff can only work in one facility to limit that spread. So I only mention that because if you are going to be doing visits, it is really worthwhile to limit the number of places you're visiting, especially if those places are long-term care homes, retirement homes, other places where vulnerable people might be or where infection might live. There is always that risk of picking it up unknowingly, bringing it to another setting, and we're trying to interrupt those opportunities for spread where we can. And again, our first preference would always be a virtual visit if possible, but we know it isn't always possible. And so it is about reducing the number of places you're visiting where you can.
Yeah, that's great. Thank you for that. Maybe related to that would be the question, I guess, around contact tracing. So maybe in twofold. One, related to the question we just talked about, related to staff doing things like visiting in different places and maybe and thinking about not having too many places in one day, should those persons be keeping a log of where they've gone and what they've done, and with a little more intention, because many of us know what we've done, but be more intentional about that, and maybe even sort of the interactions, where we were, what we did, those kind of things, more journaling. And then the other side of that, should churches be preparing for some kind of contact tracing? I know you spoke a little bit about keeping a log. Is that sufficient? Or should we be, I've heard of some churches putting in place a system where they actually know exactly where everyone's sitting and have sort of like a seating plan, and then are being aware of who's in that general vicinity if something happened to one individual, in order to provide that to public health. Are those kind of recommendations necessary? Is that going too far? Just wondering.
I mean, I don't know what's possible. That sounds really impressive and robust. And if you have the capacity to know not just who's in and who's out of the building at a given time, but where they're actually sitting or where they are, more information is always helpful as far as our nurses who try and identify close contacts. So if that's possible, that would be great to have. But I would say as a baseline, at least having a list of people who are in the space at a given time as part of a particular service, that really is first and most important piece of information, because then we would contact, if we had a person who was a case and they knew they were part of a service on a Sunday morning on this date at this time, then we would be able to contact church and find out who else was part of that service, and then begin contacting those people to find out whether or not they had close contact with that case. If you have more information that helps inform that assessment of close contact, that is that much more helpful to us. To your question about if you have clergy or staff or volunteers who are visiting people outside the church setting, keeping a log is a great idea, because that way, if that person ends up becoming a case of COVID-19, and again, it makes it that much easier for us to speak with them and find out where they were, and not just where they were, but what activities they participated in. Because we would ask them, if you visited this person, were you having a conversation from across the room, maintaining a physical distance, versus you have to get up close, interact with them, the person, touching them. Those carry different kinds of risk, and the recommendations for how that person is managed changes as a consequence. The more information, the better. And if you're able to get information about not just what people are in general, but what activities they're participating in, that is helpful to us.
That's excellent. Thank you. So maybe just following on that, if there was a case that came out within the context of a church setting, someone became symptomatic or contracted COVID, and somehow that got to you guys, and then you contacted that person was then contacting, through them, they contacted the church or contacted others that were involved. How should a church respond to those kinds of things? I guess in two questions within that, the sort of the sense of, what if, because sometimes churches can find out information about members of their congregation that they may not be reporting to public health or to the hospital or whatever, depending if the symptoms were severe or not. Like, we might find out that someone attended and then a little later, oh, they got these sort of symptoms. And we're thinking in our minds, oh, did you go to the doctor? Did you go to the hospital? No, I'll be fine. But could that be concerning? And should that be reported to someone in authority around the health authorities? And then the second piece of, just when that does happen and we get that call or we're contacted that someone in our service who attended on a Sunday has been diagnosed with COVID, how are we to respond? Like, would the church need to be shut down? Would it need to be everyone who was attending that day isolated for the day? Or do you guys at Public Health run through a protocol yourself that you offer to each individual as opposed to the institution itself?
That's a really good question, and that gets at sort of the nuts and bolts of what we do with our management of COVID cases and COVID outbreaks. To your question at the beginning about if you have someone who comes and you screen them at the door and they say they have, runny nose, sore throat, if that person is then asked to go home and they do, that doesn't need to be reported to us. If that person then gets tested and that test comes back positive, that gets reported to us through that healthcare provider and through that lab, and so we find out about it that way. For all of the concern we have about people who have symptoms having COVID, there are also going to be other things, whether it's flu or colds or other things that circulate from time to time that cause those symptoms. And so not every one of those cases will be of concern to us, but when someone with those symptoms ends up becoming known to have COVID, information finds its way back to us. So if you have someone who just has symptoms and they don't come in, that's no problem. We'll find out through another way if they become a case. If you find out through your community or just through avenues of information you have, someone who is at your service or in your establishment was a case of COVID-19, that would be information we'd appreciate finding out, and you can give us a call to let us know about that. There's a good likelihood that we would already have that information, but just in the interest of redundancy, in the interest of not missing a possible case, it would be helpful for us to know that information. And so you can give us a call on our main line and we'll take that information from you. I will say in the outset that because of the way that privacy laws work, we can happily receive that information and give you back certain kinds of information. We won't be able to fully share all that we know or share the outcome of that process because we have to make sure we respect the privacy of people's health information as we investigate. So I'll sort of say that at the outset, but we certainly appreciate receiving that information. If there were to be an outbreak, meaning concern that there was spread of COVID between person to person inside that place of worship or that church, that would be a scenario where we activate our outbreak response team. We would engage directly with you and the people who work at your place of worship to talk about how to manage that. And each outbreak investigation and each outbreak plan is always a little bit different because nature of the exposure between people is different and the kinds of solutions we can implement are different. So if we had a case of COVID-19 who is attending a church service, for example, we would speak with you about what kinds of services are happening that morning. Were people sitting in pews or seats spaced apart versus was there something going on that caused people to mix more than usual? What was kind of the scenario in which people were there that might lead us to better understand what opportunities existed for transmission? So there's an investigation piece to that, and we'd work with you to better understand how things looked on that day. And then based upon that information, we would do a risk assessment. We would figure out who needs to be followed up with and how, both in terms of congregants, people visiting, people who are there as volunteers, clergy, staff, everyone who could be part of that scenario, we would develop recommendations for. And then when it comes to things we would hope you would implement in response to that, we would work with you and give you recommendations, then reduce the risk of any further spread in your setting. So that isn't unlike what we do right now when it comes to working with long-term care homes, retirement homes, and we now have workplaces that have COVID-19 outbreaks. We always understand the scenario, understand kind of the picture of how things could have been passed person to person, understand what the context is for how we can intervene, and then work with you to develop some solutions that will reduce further risk. But it is a bit contingent on the scenario.
For sure, that's great. And then just a couple more of the prepared questions, and then we can open it up again to folks. There is somebody on the call today from Rockwood, and it's a very Rockwood specific question. Diane Boyd is on the call, and she was wondering about Rockwood specifically, and just wondering if you could give a briefing on total cases resolved, newly confirmed, deaths, things like that, like for her own community's sake. I think she's looking for that.
Yeah, so I don't have data specifically for Rockwood, and we actually are really deliberate about, we release data at the WDG level and as well at the level of the city of Guelph, the county of Wellington, the county of Dufferin. The challenge of going further down and doing smaller geographies than that is that the numbers get much smaller. It's difficult to run analyses on them. And numbers don't reflect risk in a meaningful way. And what I mean by that is that people who live, when we find out about cases of COVID-19, we get information about that case, we find out their address, and then that's how we code where we assign that case. So it's based upon where they live. And we know that where people live and where we categorize that case as being is not necessarily a reflection of where they work, where they visit, where they gather, and where they got the infection. So even if we were to say Rockwood has this many cases and it's higher than a neighboring municipality or a neighboring area, I think there is a real communications challenge because that doesn't necessarily mean that people in Rockwood are at greater risk of COVID-19 than people in a neighboring area. Our message that we've been trying to say clearly is that COVID-19 exists in our community. There are risks anywhere. It exists in places where we don't always know where it came from. We can't always track down the source of every single case. And so there are cases that are being undetected in all parts of WDG. And realistically in all parts of the province and the country. And so assigning case numbers to really small areas is not something we've done because we don't think it's meaningful information in the way that data about larger geographies is. I realize that may not be a satisfying answer, but that's our rationale.
Sounds good.
Thank you.
Yeah. So then just maybe a curiosity, it's sort of combined with a couple of questions, and we've already touched on it a little bit. We're wondering about when, from a professional in public health, when do you think it would be acceptable, appropriate, safe to visit people in their homes and in long-term care facilities? I mean, I got a sense that you're saying that if that's part of your role, then by all means do that. But if there's ways you could do that virtually or differently, then that would be great. I guess we're all in sort of this pattern of we've been kind of on lockdown for several months, and we're kind of wondering, well, is it appropriate for me to go and visit so-and-so in their home just for the regular practice of what we do as a part of our faith community? Do you have a comment or a thought on that? Is that, yeah.
I'm happy to comment on that. It's not going to be a very precise answer because it is not well defined. It's kind of a judgment call, and it's based upon information that's changing day by day and week by week. I'll start with long-term care because it's a little bit easier to answer. We know that we had a lot of activity as far as long-term care home outbreaks, in particular over the months of April and early May. It seems like we have much less activity in our long-term care homes right now than we used to. We don't have any current homes in outbreak, whereas previously we would have 5 or 10 on a given day in outbreak during our busiest points. So we think that there is less activity of COVID inside these long-term care facilities. That being said, we are still quite concerned about the opportunities that exist because of the fact that people are in close quarters, because of the fact that we know there are opportunities for improvement when it comes to infection control practices. We know it's a vulnerable population, and so there are really, there's a heightened vigilance we have in that setting, and so we might resume visits and services there more slowly than the data itself says. And we look to the provincial guidance around long-term care homes, just for the sake of consistency across the province. And right now they have just reopened, allowing non-essential visitors back in under very strict circumstances. Essentially, you can have an outdoor visit where you're wearing a mask and you're maintaining a 6-foot distance. And it would be appropriate as part of that gradual reopening to visitors for clergy to visit residents in long-term care or retirement homes, because those are reasonable measures to reduce the risk of transmission. Again, it's always a judgment call, and what the recommendations are is going to change based upon whether as a community we do better in the future or we do worse. But I would say look towards the broader long-term care visitor guidelines and abide by those in taking your cue about those visits. When it comes to visits in a home setting, it's a little bit trickier because there's a bit less guidance. We do know that there are some home care health service providers who are doing their visits because they provide essential health services and they need to do that. And they go in wearing appropriate personal protective equipment to be able to do that work. And there is a risk there, but in that scenario, the risk that has to be counterbalanced against danger to someone who's not receiving an essential health service. When it comes to having clergy visit in homes, there is a bit of a judgment call involved. What I would say is that if you're able to do it in a way that's physically distant, you're able to do it wearing a mask, if you're able to avoid doing it where possible, where someone is known to be isolating because they have COVID, those are all important considerations. And I would say that fewer visits, better, in terms of the overall number of contacts someone has. We're talking more broadly in our community about having bubbles of no more than 10 people. And so if you think about if you're visiting all these people and people are entering your bubble, how many people are in your bubble as a consequence of that? And so I would certainly avoid any close contact with people if you can. You can consider doing more physically distant visits if that's possible. But again, fewer people and fewer visits is better.
That's really helpful. Thank you. I'll open it up again if anybody on the call today wants to offer a follow-up question or particular questions. Yep, Rafe, go ahead.
Yeah,
Just a couple of things. First of all, I appreciate what you said, and it's very helpful. Our Anglican House of Bishops, which covers all Ontario, is being very conservative. We still can't gather with more than 5 in the church, and it's just for online virtual celebrations of worship and things of that nature. And there's directions coming now about masks and things of that nature as well, even for those 5 when they aren't doing their bit. So, and in terms of visiting, the only visits that we could do is in a pastoral emergency, like somebody's dying.
Okay.
And that one again is a judgment call, right? And so we work that there. I know because I made an appointment for the end of July to get my haircut, but then I was set this form that I'm supposed to fill out, sort of waiving all my rights, and do I know and do I know this, that there's maybe some issues of liability that we'll have to think about with the church, but that's not your issue. That'll be the insurance companies that tell us what we can do. And I know my House of Bishops will be listening very, very well to them, because they seem to direct the church as much as anybody, the insurance companies being that. But we have a daycare here, a large one, which is looking at trying to figure out how to come back, and Workside's an early childhood education center. And they have points, multiple points in our building, exclusive use points, but there'll be travel and all that. What I've heard recently is that there's been a shift, particularly in the States, where they're doing things in a very haphazard way. But the rise right now is among younger people getting infected, and even children, and spreading things. So with a congregation on one side and then a 5-day-a-week presence on the other side, we have some issues of worry, and it comes down to things touched. You said probably don't have books around if you can keep those away. And I know a lot of people have said, well, those are hard surfaces. If they're used once a week, they should be fine. But we've already decided to move ours out and go to print off things and things that can be recycled and thrown away. But just having sort of different programs in space, even though we're a large space. I mean, if we opened at 30%, we could have 150 people at church, which we never get in the summer anyway. But we don't want to start there, because it's about how do you get them in safely, how do you get them out, how do you travel them through. But I do have that added thing about the daycare, and I know they have a whole host of things. How are they going to actually come back? The limits that have been put on them. How is it going to be paid for? They have so many issues right now. But my issue is about the transmission possibilities when you have these types of overlapping uses.
That's actually a really excellent question, and it depends on how things are laid out physically and how people might interact in that context. We have our own set of guidance for child care centers, and those would be the guidelines that apply to that sort of side of things. If you were able to run both the church and the daycare as essentially separate services, separate physical spaces, no shared facilities, then they more or less could run each under their own recommendations in parallel without too much of a problem. I think the challenge would be that if, for example, you had shared washrooms, shared meeting or lounging spaces, shared common areas, then there might be that person-to-person mixing that we think about. And as well, you have opportunities for, if you have a child who has COVID-19 on the one side, and they touch a faucet in a shared washroom and it's not cleaned often enough, and then it's touched by someone else on the other side, you could have that spread back and forth. So what I would say is that if there were ever a case of COVID-19 on sort of either side of that scenario, we would work with you to figure out whether there is really a risk that spans both settings, or whether it can be effectively isolated to the one side, based upon the particulars and details that apply when we do that risk assessment. As a preventive measure, if you can keep those two groups apart as much as possible, keep facilities apart as much as possible. If you have shared facilities, then ensure that they're being used at different times by different groups and they're being cleaned in between. All those things really help to isolate any spread and keep it from moving between the two groups. Beyond that, I would say, look towards the guidance for places of worship on the one side, guidance for daycares on the other side, and then really keeping them apart is the key message there.
Thank you.
Diane, did you have a question as well? Go ahead.
Yes, I did. My question is in regards to preaching. So when we preach, we're projecting our voice and, you know, sharing our droplets. What would be your suggestion for us? Should we wear a mask, which would make it difficult for those with hearing problems to actually hear us? Or would you suggest a shield? Or what would be your suggestion with that? Because we do project our voice, much like singing.
That's an excellent question, and there are sort of a number of different options. The scenario I'm picturing in my head is one where if you're preaching that's from a spot like a lectern or a pulpit that is physically removed from where congregants are sitting, at least 6 feet, probably more. Is that a fair assumption?
Yes.
Okay. Then in that setting, there are a few different things. One of which, as you mentioned, is a mask that will sort of stop droplets from coming too far out of your mouth as you're speaking. And that unfortunately has the downside of making it more difficult to hear. That might be counterbalanced by the use of a microphone. And a microphone might also help in any circumstance because it reduces the need to raise your voice. If you're able to preach in a way where you're speaking softly into a microphone that amplifies you, that will lead to less projection of droplets than if you're having to raise your voice, shout across a larger room. So masks may be helpful, but have some downsides. Microphones may either alleviate that or provide a way to speak softly. As well, having a physical barrier is really a good idea as well. So if you're able to, whether it's a face shield or some sort of plexiglass or transparent shield that comes up in front of you and separates you from the congregation, that should be able to stop droplets that are coming out of your mouth from, you know, coming into contact with anyone sitting in front of you. And so you can use any combination of those things. And in fact, using all of them in combination will reduce the risk the most. The idea is you're taking a multi-barrier approach. So you are thinking about what is everything I can be doing, both to reduce the number of droplets coming out of my mouth and also to reduce the chance of that droplet from moving across the room into someone else. So masks, microphones, a physical barrier are all worth considering.
Thank you.
Just as a follow-up to that, if some of our spaces are such that we're probably, I don't know, as much as 20 to 30 feet away from the first human, and we could even space our facility so that there's people not in the front rows, which they rarely ever sit in anyways. Would that be acceptable from like not needing to wear a mask for when you're doing that? Obviously wearing a mask all the other times, but once you're in that space and there's the next nearest person is like 30 feet away, would that be acceptable?
Certainly if people are 30 feet away, the likelihood of a droplet that's coming out of your mouth going that far is pretty remote. Usually we think about 2 meters being the distance we're worried about. So in that sense, I'm not terribly worried about that scenario. The question I'd have is, in that scenario, if you are 30 feet away, are you always 30 feet away, or are there times when you're going to be coming into closer contact? Because those are scenarios when masking is important. You might be aware that recently Dr. Mercer, a medical officer of health, issued an order basically saying that for any commercial establishment, you have to wear a mask while you're in there because of the fact it's really challenging to physically distance. We are really trying to push hard on the norm that if you aren't able to physically distance, or you're in scenarios where that could become challenging, you really should be wearing a mask. If, as a preacher, you are always 30 feet away, to me, that's a scenario where you are physically distant. If you're not consistently doing that, then a mask is really worth using.
That's fair. Great. We only have about a few more minutes, and I wondered if you had any other things you just wanted to offer to us. Just as a piece of information, I don't know about every single person on the call today, but several of us, certainly within the city of Guelph, have decided not to open to in-person worship at all until September for that conversation. So just so that you guys know, we know other churches are doing it differently and other faith communities are also doing that differently, and you know, that's up to them to make those decisions. We've made those decisions, and what we're doing right now is most of us are in the planning stages. So trying to figure out what, based on a lot of the stuff you've talked about today, how we're going to make sure our staff are trained, make sure we have the supplies we need, make sure we get a sense of the protocols, and we're also aware that things will change perhaps over the summer, as they've been changing every single day during this process. So just to let you know about that for at least within the city of Guelph, and I think some others within the Anglican tradition and the United Church tradition, and some Presbyterian churches as well throughout the region are also thinking of this as a way of reducing, mostly also because summer tends to be a lower time for us, which on the one hand would be, well, then that would be less people. On the other hand, it would be, well, let's not take the risk for that, for the sake of that. So just so you're aware of that. I wondered if you had any final sort of comments that you'd want to offer. And you also had suggested that you'd send some resources. I'd be happy to receive those, and I'll send those out after this call today.
Yeah, thank you very much. And I think just to build off of what you had said, this is a constantly changing circumstance, not just in terms of numbers of cases and the epidemiology of COVID, but even in terms of the news. Like every day when the Premier holds a press conference, there's something new for us in some way, shape, or form as a community. And so there are these provincial directions right now on what can or can't be done in places of worship. That can change. And so I encourage everyone to keep a close eye on what's coming from the province. As well, we understand that there's going to be a provincial guidance document laying out in more detail what the province is recommending on resumption of services and places of worship. And so as soon as we receive that, I'm happy to share that along. In the interim, I'd mentioned that One Health Unit had worked on something. So Toronto Public Health has actually put together a really good document that they developed while we were waiting for the provincial guidance document. Ordinarily, we would develop our own, but I'm wondering if it's just because that one is so good, I'm just happy to share that one to you. And it is quite detailed, has a number of considerations, not just of what to be worried about, alternatives, how to operate during this time to minimize risk. And so I will share that, as well as if there's any further provincial guidance, I'll share that as well. And I just want to say I appreciate the chance to speak with you, and I see this as the beginning of a conversation. Things are changing, and if you want to reach back out, please do, and we'll happily provide more guidance as best we can to support you. We know that in our community, everyone is trying to do their best, and we are living in a really challenging time where we have new rules that are unusual to us, and that applies to us in public health as well. And we're not expecting anyone to be perfect or to have a plan that works from day one, but as long as we all work together, we're continuing a conversation, we're trying our best in good faith to do everything we can to protect our community. That's all we can ask of you, and that's what we want to support you in doing. So I want to thank you for your time today, and I hope we'll connect again as needed to be able to ensure that we're supporting one another.
Thanks so much for your time, Doctor. Really appreciate it, and all the best to you as you continue to do your hard work. And yes, let's keep in touch if we can, and if there are some documents you want to share, I'd be happy to push them out to the folks that can share them more broadly with other faith communities in town. Thank you so much.
Thank you so much, Reverend Borthwick.
All the best.
Thank you.
Yeah, take care.